Hey NP students, we're going to start something new. It's going to be called the Cram Clinic. So I'm going to try to teach you guys about common illnesses that you will see in your clinical. So when you go, you're not looking crazy and you actually know what you're talking about. Today we're going to talk about hypertension management or hypertension treatment, and we're going to talk about JNC8 and AHA. So JNC8, that's your old homegirl. These are the old standards. They've been around longer than 10 years. With JNC8, we're going to want people's blood pressure to be lower than 140 over 90. And if they over 60, then we'll let them slide 150 over 90. She's more lax. We're going to name JNC8 Janet because Janet sounds like an old, and she's older. Okay? Okay, so now for ACA/AHA. I always have a problem pronouncing that. We're going to call her Anna because she's a strict. She doesn't want your blood pressure to be any higher than 130 over 80. So that's most of us. So she is definitely going to be the more strict of the two parameters. Most clinics now and most hospitals are going to be using the ACA/AHA since JNC8 is a little outdated, but you need to know both for your boards, and it's good for you to know when you're going to your clinicals for the first time. I know when you're in nursing school, the first thing that you think is probably beta blockers for treatment of hypertension. But now that we're in NP school, we're going to get to the nitty gritty of it. So for NP school, we're going to remember A, B, C, D. So A is going to be for those ACE inhibitors and ARBs. The B is going to be for beta blockers. C is going to be for calcium channel blockers. And D is going to be for diuretics. So with those ACE inhibitors, we're going to want to remember they do produce a cough in some people. If the cough is bothering the person or the cough is severe enough or we see some swelling in the neck, that's going to be indicative of angioedema. Okay, so we're going to want to stop that med and we need to switch them to something else. Most of the time they switch them to a sartan, but you do have some providers out there, they'll just go ahead and put them as an allergy to an ACE and an ARB, and they'll switch them to totally something different. Thiazide diuretics are going to be good for African Americans and also people with osteoporosis. So they prescribe those a lot in the older population. Our calcium channel blockers, we're going to want to avoid those in people with GERD and people with heart failure, okay? And you're going to watch for peripheral edema or ankle edema with those meds, okay? And then the last thing, our beta blockers, we know is going to slow it down. It's just going to slow down that heart rate. And it's not typically going to be a first line. Typically, we use it in conjunction with something else if one single med by itself is not working. The first thing I should have mentioned is lifestyle prevention or lifestyle changes. That's one of the first things that we want to do when someone is coming in with hypertension. And sometimes it could be nervousness, it could be that white coat syndrome. So we just don't want, as soon as someone comes in, if they only have that one reading, we need 2 readings so we can diagnose blood pressure. We're not just going to start them on meds. We want to do lifestyle changes. So we want them to lose weight. We want them to implement the DASH diet. We want them to start exercising, whatever we can do to get them to lose weight to hopefully get that blood pressure down. Now, if they come back in 3 months at their follow-up and their blood pressure is still high, then that's when we'll start on one of the meds that we mentioned. And after you start blood pressure medications, you always follow up within 4 weeks, 4 weeks or 1 month. Same thing. They mention it different on different questions. Okay. So we also want to watch out for resistant hypertension.